Okay. A warm good evening, everybody. And this is a NEET PG 2020 series that we are doing for the upcoming NEET PG examination. I hope you have attended the exam. I've kept it very baseline questions in radiology, keeping in consideration the NEET PG aspects. And let us quickly look into these questions one by one. Just let me know if you have attended the exam and how did you find the exam. Good evening, Ronak. Let's get started with the first question here. A 25-year-old young male presents with abdominal pain after sustaining blunt trauma abdomen. During an RTA, has a blood pressure of 120/80 and a pulse of 72 beats per minute. The next best step in management of this patient is, can you tell me what is this abdominal trauma patient coming to you with blunt trauma abdomen? BP is stable, pulse rate is stable. What is the next best step in the management? Good evening, John. Yes. So the blunt trauma abdomen, the next investigation that you have to do is a FAST, that is focused assessment with sonography. So the answer here should be ultrasound. So remember, whenever we have a blunt trauma abdomen, the first investigation we have to do is EFAST, that is extended fast or FAST. And if FAST is positive, that means there is hemoperitoneal. And if FAST is negative, that means there is no hemoperitoneum. What would you do if FAST is positive? If the question mentions that ultrasound was done and FAST is positive, the next thing is look for the vitals. Good evening, Karthik, Ronak, Grace, right? So what would you do if vitals are stable? Vitals are stable. What is the investigation? CECT. And if vitals are unstable, the next investigation is emergency laparotomy. Emergency laparotomy. Emergency laparotomy. So if the FAST is stable, if the FAST is positive and the vitals are stable, you go for CCT. And CCT will tell you the organ of injury, to know the organ of injury. If the contrast is coming from the liver, that is a hepatic injury. If the contrast is leaking from the spleen, if there is a contrast blush from the spleen, that is splenic injury. So to know the organ of injury in blunt trauma abdomen, we go for CCT. And in unstable patient, we go for emergency laparotomy. So this is the basic protocol. Let's look at the next question. Name the condition. Stable patient, CECT only, right? So that is what we have discussed, Monica, right? Stable patient, we go for CECT to know the organ of injury. But if it is unstable, you go for emergency laparotomy. And can you tell me, when is FAST not useful? FAST is not useful in which conditions? In trauma patient, blunt trauma abdomen, FAST is not useful in. In case of fluid less than 100 ml, FAST may not pick up the hemoperitoneum if it is less than 100 ml. FAST is not useful when the patient has subcutaneous emphysema on the abdominal wall. Subcutaneous emphysema is there on the abdominal wall. Air will be white. It will be reflecting the sound. So you cannot go deep in and see the hemoperitoneum in the patient. So please remember, in subcutaneous emphysema, FAST may not be useful. And FAST is not useful. Very important limitation of FAST is retroperitoneal hematoma. What is the investigation of choice, guys, for retroperitoneal hematoma? Retroperitoneal hematoma, this investigation of choice would be CECT, right? CECT. This is the important limitations of FAST. Let's look at the next question. Name the condition based on the image obtained from a newborn. What do you think is this? Let's look at the second question. So you can see here, there is a metal button at the anal dimple. There is a gas in the rectum. You are measuring this distance between the metal button and rectal layer. And the child is upside down, his inverted position. This is invertogram. What you're doing here is invertogram. Invertogram. And what is invertogram done for? Very good. Everybody's answering it correctly. This is imperforate anus. Invertogram is done for imperforate anus. Invertogram is done 24 hours after birth. So you need to wait for the gas to reach till the rectum, right? And invertogram is done to evaluate whether it is high anal atresia or low anal atresia. If this distance between the metal rectal layer is more than 2 centimeters, it is said to be high anal atresia. And if it is less than 210 centimeters, this is considered to be low anal atresia. So basically, to evaluate anal-atresia or imperforate anus, we do invertogram. The child is upside down position. The invertogram is not done immediately after birth. You need to wait for the gas to reach till the rectum. So it is done 24 hours after birth, right? This is invertogram. So the answer is imperforate anus. Let's look at the third question. A 40-year-old male with 2-year history of mucopurulent cough underwent a CT chest. What is the most likely diagnosis? What do you think is this image showing you? A 40-year-old patient, mucopurulent cough, CT chest is given to you. What do you see in this image? What do you think it is? Bronchiectasis, cystic fibrosis, sarcoidosis, or pulmonary hydatidosis? What do you think is this? What are you seeing here is multiple cystic areas giving a bunch of grape appearance. This bunch of grape appearance that you are seeing, this is condition suggestive of bronchiectasis. You are seeing bunch of grape appearance. This is cystic bronchiectasis. Right? Especially in the lower lobes, you'll have this bronchiectasis. Most common site of bronchiectasis is lower lobes. Right? So this is bronchiectasis. Look at this next question. A 40-year-old male patient on long-term steroid therapy for systemic disease presents with recent onset of severe pain in the right hip. Imaging modality of choice for this problem is. Can you tell me what is the fourth question? Answer. What is the answer for the fourth question here? Fourth question. So basically, you are having a long-term steroid and hip pain. What do you come think of? This is avascular necrosis of the hip. So very good, Anuj, Asmita, John, right? Good, Indu, right? So this is avascular necrosis. An investigation of choice for AVN is MRI. This is the investigation of choice for avascular necrosis. In orthopedic conditions, I want you to learn MRI for a few orthopedic conditions. Just remember this. MRI is the investigation of choice for avascular necrosis. Avascular necrosis in young, what is that called? Perthes, right? So even for Perthes disease. It is also the investigation of choice for acute osteomyelitis. Also the investigation of choice for ankylosing spondylitis. Stress fractures. March fractures. Okay, stress fracture or march fracture. Also we go for MRI. And to look at cartilage also, to look at the cartilaginous cap of osteochondroma, we go for MRI. So these are the important indications where MRI is needed. MRI for ankylosing spondylitis, avascular necrosis, avascular young people, stress fracture, march fracture, as well as for cartilage. This is MRI. Next, fifth question. Try to answer this. What did you mark for this? A 60-year-old female with intermittent bleeding per vagina. So it's an elderly female. She was having bleeding per vagina. Endometrial collection and thickening is seen with anterior bulging of the fundal area on ultrasound with a feeding vessel sign. What is the most probable diagnosis? So there's an anterior bulging, there is a focal bulge, and there is a feeding vessel sign. What did you mark this as? So remember, both endometrial polyp and endometrial cancer, both of them have endometrial thickening. A focal thickening will be usually endometrial polyp. Endometrial cancer generally is a diffuse thickening. And how do I differentiate whether it is a focal thickening or a diffuse thickening? So imagine this is the endometrial thickening. And how do I know this is a focal thickening or diffuse thickening? I put a catheter and inject the saline and distend the endometrial cavity. So when I distend the endometrial cavity, I can know whether it is a focal thickening or a diffuse thickening. This procedure whereby infuse saline and do ultrasound, this is called saline infusion sonography. Saline infusion sonography. So I am seeing a focal thickening now. And I press a color Doppler button. I am seeing a vessel passing through the pedicle of area, through the stalk of the polyp. You are having a vessel passing. This is the feeding artery sign or pedicle artery sign. So on color Doppler, if you're seeing this feeding artery or pedicle artery sign, a focal thickening, a focal bulge is mentioned, and there's a feeding artery or pedicle artery. This is endometrial polyp. Endometrial polyp. So the answer should be endometrial polyp for this. Next thing. Can you answer this one? Sixth question. A cancer patient undergoing radiotherapy is given a dose of 1.8 to 2 gray once daily for 5 days per week for a duration of 6 to 8 weeks. What is this type of radiotherapy called? Can you tell me what is this? What did you answer this? A cancer patient undergoing radiotherapy is given a dose of 1.8 to 2 gray once daily for 5 days per week for a duration of 6 to 8 weeks. What is this type of radiotherapy called? Very good. So if you're giving once daily dose, 5 fractions per week, 5 fractions per week. Monday to Friday, once daily dose is given. This is regular or fractionated radiotherapy. Hyperfractionated is more than 5 fractions. If you give more than 5 fractions, it is hyperfractionated. And how is it possible to give more than 5 fractions? By giving BD or TID doses. And it is usually given for, aggressive gliomas, aggressive cerebral gliomas, small cell lung cancers. So any aggressive tumors are there, we want to give BD and TID. So we go for hyperfractionated. Basically, 5 fractions, more than 5 fractions or less than 5 fractions. If it is less than 5 fractions, it is hypofractionated. And this is usually palliative measure. Like, for example, bone metastasis is there. We give one dose of 8 gray. So single fraction of 8 gray is given. So that is hypofractionated. And what is accelerated radiotherapy? When we try to complete the radiotherapy very fastly, within 4 to 6 weeks, there is a continuous hyperfractionated accelerated radiotherapy. That is called chart regimen. What is chart? Continuous hyperfractionated accelerated radiotherapy. In this, all 7 days we give, including Saturday, Sunday. Hyperfractionated is BD or TID doses, right? More than 5 fractions. Accelerated, where we complete within 4 to 6 weeks. This is chart regimen, and this is used for non-small cell lung cancer. Non-small cell lung cancer. Once again, the most regularly done type of radiotherapy, the conventional radiotherapy, the regular radiotherapy is a 5 fractions per week, Monday to Friday, once daily dose. This is the regular or fractionated radiotherapy. Hyper means more than 5 fractions. But when you give BD or TID doses, that is hyperfractionated, given for aggressive tumors like small cell lung cancer or aggressive glioma. Hypofractionated is less than 5 fractions. That is done for palliative radiotherapy. That is for bone metastasis. Accelerated radiotherapy. This is used in chart regimen. Cell lung cancer. Fractionated accelerated radiotherapy. This is for non-small cell lung cancer. Next. This is easy question. I hope you have answered this. 7th one. 35-year-old male presenting with recurrent episodes of abdominal pain, jaundice, and fatigue underwent MRCP. What is the most likely diagnosis? So this is a patient with abdominal pain, jaundice, and fatigue on MRCP. What do you see on the MRCP image? You are seeing repeated stricture and dilatation of the biliary tree. Right? This is a prune tree appearance on MRCP. We call this as prune tree appearance. Prune tree appearance on MRCP, or similar image can also be seen on ERCP also. On ERCP image also, you can see the prune tree appearance. This is suggestive of primary sclerosing cholangitis. Right? So the answer should be primary sclerosing cholangitis. And do you remember any radiological sign with Caroli's disease? Do you remember what do you see in Caroli's disease? Caroli's disease, this is a type 5 choledochal cyst, right? So intrahepatic biliary dilatation you have. Can you tell me any radiological sign? So because of the intrahepatic biliary dilatations, the bile ducts are dilated inside in the liver. Outside is okay. Extrahepatic is fine. Intrahepatic dilatation are there. Adjacent to this, you see the portal vein. Adjacent to it. So when you take a section, you see a dilated hepatic duct adjacent to portal vein. What do you call that appearance? That is called a central dot sign. Central dot sign. So central dot sign. This is Caroli's. So remember, central dot sign is feature of Caroli's disease. Central dot sign is Caroli's disease, type 5 choledochal cyst, right? Intrahepatic biliary dilatation. Next thing. This is easy. 12-year-old child taken to the hospital with fever and fatigue. Chest X-ray is given. What is the likely diagnosis? Is it a snowman appearance of TAPVC, boot-shaped heart, egg-on string appearance, or box-shaped heart? The terminology is correct, matching with the same condition. But what is this actually? You can see the image carefully. You see this snowman or figure of 8 appearance. Snowman or figure of 8 appearance is supracardiac, only in supracardiac type. Supracardiac TAPVC, right? So this is snowman appearance, supracardiac type of TAPVC. We'll show you this. Okay. Then Another question. There was a question asking you, a patient is having progressive dysphagia both for solids and liquids. And he's having BMI of 18.5. He's having no systemic illness. The barium swallow is done and is shown what should be done in this patient. So what does a barium swallow show? There is a bird beak appearance. Okay, bird beak appearance on a barium swallow. You know this is achalasia. Achalasia. So what should be done for this? What should be the answer for this? So achalasia, you go for manometry, and you also go for upper GI endoscopy to know whether any kind of pseudoachalasia is there, any tumor compressed area, distal esophagus. So you like to go for upper GI endoscopy also and manometry also. 24-hour pH monitoring is done for GRD, right? Gastroesophageal reflux disease. So answer here should be upper GI endoscopy with manometry. Now 10th. What is this 10th question? An industrial worker was admitted to the hospital after injury to the eye following his work with hammer and chisel. This is commonly tested hammer and chisel injury. And foreign body was impacted in his eye. Which of the following investigation would be detrimental in the patient? Detrimental means harmful, okay, which is harmful in this patient. So whenever you're given hammer and chisel and you are seeing a foreign body in the eye, strongly suspect intraocular metallic foreign body. So you're dealing with intraocular metallic foreign body. Intraocular metallic foreign body. So whenever you see this patient working with hammer and chisel, the investigation that you have to do, right, for intraocular metallic foreign body is a CT scan. And which investigation is contraindicated? MRI is contraindicated. So you just need to understand which is detrimental or harmful. So obviously it is a metallic foreign body or iron foreign body. You will have the iron foreign body inside. So obviously MRI should be contraindicated. So this patient who is working with hammer and chisel sees a flying foreign body in the orbit, think of intraocular metallic foreign body. Investigation of choice is CT, but here the question is asking detrimental. Answer should be MRI. Next, 11th, a patient with a history of left upper quadrant breast cancer. So there is a left upper quadrant breast cancer. Underwent cobalt-60 radiotherapy. Remember, cobalt-60 is used in external beam or teletherapy, right? It is gamma rays that are used by cobalt-60 resource. She is now presenting with respiratory difficulty and chest X-ray shows haziness in the left lung. So you're seeing the haziness in the left lung. What is the most likely diagnosis? What did you mark for this? Very good, John, Anuj, right? So this is a cancer patient undergoing teletherapy, and you see a haziness around that area where you have the left upper quadrant cancer. So around the same left upper quadrant, you are seeing this opacity there. This is radiation pneumonitis. So in the place of the radiation being given, you see this patch of, pneumonia there. This is radiation pneumonitis. This is because of the radiation exposure you're having. You see this distinct area along the port of the radiation port that you have. You have that patch also around the same area. So this is radiation pneumonitis. Okay. A patient presents with epistaxis and is diagnosed with juvenile nasopharyngeal angiofibroma. What sign is given here? So if you see the maxillary sinuses on right side and left side, which maxillary sinus is appearing smaller, right side or left side? Which is appearing smaller? The right side is appearing smaller. The right maxillary sinus, the antrum of the maxillary sinus is smaller. And is it because of the problem in the anterior wall or the posterior wall? It is a problem in the posterior wall. There is an anterior bowing of posterior wall of maxillary sinus. Look at the posterior wall here. Look at the posterior wall here. You are seeing anterior bowing of posterior wall of maxillary sinus. This is called as Holman-Miller sign or the antral sign. Okay, this is also called as antral sign. Holman-Miller sign or antral sign. This is seen in juvenile nasopharyngeal angiofibroma. Juvenile nasopharyngeal angiofibroma. Next. Okay. 13th. A 65-year-old female fell down in the bathroom and sustained head injury. CT scan is performed. What is the likely diagnosis? What did you mark for this? What did you mark for this? This is easy. You are seeing this white area. This is acute bleed. Acute bleed is hyperdense. Acute bleed are hyperdense. Hyper means white. And this is the chronic bleed. Chronic bleed is hypodense. Chronic bleed is hypodense. So acute bleed is hyperdense and chronic bleed is hypodense. And you are seeing a crescentric area. Concavo-convex. Crossing sutures. It is crossing the sutures, but not crossing the midline. So you can see it is not crossing the midline. It is crossing the sutures. The frontotemporal sutures are crossed, but not crossing the midline. So that will be your SDH. This is acute on chronic SDH. Acute on chronic SDH. So this is acute on chronic SDH. So that should be a better answer. Okay, that should be a better answer. Clear? Next. Remember, acute bleeds are hyperdense and chronic bleeds are hypodense on CT. Okay, 14th. A 55-year-old female with headache, MRI image is given. What is the likely diagnosis? Female, reproductive age group. MRI is showing you a lesion which is enhancing broad-based towards dura, broad-based towards the dura, attached to the dura, showing a thickening of the adjacent dura. This is called dural tail. There is a dural tailing. There is a dural tailing. So this is suggestive of what? Meningioma. Can I ask you, multiple such lesions are seen in which condition? If the question says multiple such lesions are seen in which condition? If I give you options like NF1, NF2, von Hippel-Lindau syndrome, or Sturge-Weber syndrome, what is your answer? Can you tell me what is this? If I ask you, multiple such lesions are seen in which condition? If I modify the question and ask multiple such lesions are seen in which condition? This is definitely NF2, Miss Me lesions. NF2 is what? Miss Me lesions. Multiple inherited schwannomas, meningiomas, and ependymomas. Multiple inherited schwannomas, meningiomas, and ependymomas. This is NF2. So the answer is NF2. Hemangiomas, multiple hemangioblastomas. This is seen with von Hippel-Lindau syndrome. Hemangioblastomas. That will be seen with von Hippel-Lindau. So this is meningiomas are seen in NF2. NF2. Okay. 15th question. A 51-year-old man with a history of smoking presented with pain in the right arm and ptosis. Chest X-ray is given below. What is the diagnosis? I hope you can see when you compare the apical lung zones bilaterally, you can see an opacity in the right apical region, And this is a smoker, elderly smoker, and who is having pain in the right arm and ptosis. And you are seeing an apical lung cancer compressing the sympathetic trunk, producing ptosis, and also the subclavian vessels causing the pain in the right arm. This is Pancoast tumor, apical lung cancer, Pancoast tumor. So this is Pancoast tumor. Okay. 16th. A 30-year-old male presents with sudden onset of high fever, headache, confusion, and seizures. MRI shows hyperintensities in temporal lobes. High fever, right? Headache in the patient and hyperintensities in temporal lobes. So what is the probable diagnosis? So fever patient, temporal lobe involvement. What does this suggest you of? This is herpes simplex encephalitis. Remember TB, I want you to remember it as, ring enhancing lesions, tuberculomas, ring enhancing lesions on MRI, showing lipid lactate peak. And TB meningitis would produce basal X. So look for these words, okay, and mark them. So tuberculous meningitis will show you basal exudates, hydrocephalus infarcts along with basal exudates. Neurocysticercosis, we got this in the INSET exam. Cyst with a central scolex, cyst with central scolex in the vesicular stage. In the vesicular stage, you see a cyst with central scolex. And you'll also see starry sky appearance in the calcific stage. Calcific stage. Toxoplasmosis is ring enhancing lesion. And this will be usually at basal ganglia. Ring enhancing lesion in basal ganglia, especially when you have exposure to cats, cat exposure may be given, or AIDS patient. Important is AIDS patient. So this is toxoplasmosis. So ring enhancing lesion showing lipid lactate peak, think of tuberculomas. TB meningitis will have basal exudates. Toxoplasmosis, ring enhancing lesions will be in the region of the basal ganglia usually, and AIDS patients commonly. Temporal lobe involvement is commonly seen with herpes simplex encephalitis. And neurocysticercosis, vesicular stage will have cyst with central scolex, and the calcific stage will have starry sky appearance. Okay. 17th. Yes, toxoplasmosis will also show you diffuse nodular calcification. If you want me to add calcification part, diffuse nodular calcifications. This is feature of toxoplasmosis. Okay, 17th. Elderly known hypertensive patient who is on treatment for his dementia complains of feeling of clumsiness in movements of his right hand, especially while writing since past 2 weeks. So there is a slight clumsiness in his right arm and feeling of numbness in his right face and right upper limb. A CT scan is obtained and given below. What is the abnormality noted? So on the CT scan, you can see a hypodense area in the left thalamic region, right? So in the left thalamic area, you are seeing a hypodense area. So this hypodense area in the left thalamus, this is suggestive of a lacunar infarct. Lacunar infarct. So this is lacunar infarct. So lacunar infarcts, these usually occur due to lipohalinosis of lenticulostriate branches. Right? So these are lacunar infarcts. So they occur due to lipohalinosis of lenticulostriate branches. Small hypodense areas will be there. These can be dark on CT, dark on T1, but white on T2. Right? Small infarcts, they are there. Same as, fluid signal, the fluid signal that you have, right? The small infarctions and gliosis there that can appear dark on CT, dark on T1, but white on T2 weighted imaging. So these are small in areas. These are lacunar infarcts. Eye of tiger appearance on MRI. This was again in your INSET exam. Eye of tiger appearance on MRI brain. Eye of tiger appearance on MRI brain is seen in. This is basically when you have lentiform nucleus. In the lentiform nucleus, the outer part is putamen, inner part is globus pallidus. Right? In the globus pallidus, if you have iron deposition and iron is dark on MRI, there is iron deposition. So in both the globus pallidus, you have iron deposition. Iron is dark on MRI. Right? So this condition, because of the iron deposition in the globus pallidus on the MR image, there will be dark area in the globus pallidus with a central gliosis that is seen. This is Haloverden-Sparks disease, also called as PCAN. In your INSET, the question was PCAN only, pantothenate kinase associated neurodegeneration. Pantothenate kinase associated neurodegeneration. So instead of eye of tiger, if I say tigroid appearance on MRI brain, tigroid appearance or lamellated appearance, or tiger skin or leopard skin appearance on MRI brain in a child who's having delayed milestones, tigroid appearance, lamellated appearance, right? Basically on MR, you are seeing this lamellated or tigroid appearance on MRI brain. What is this suggestive of? This is MLD, metachromatic leukodystrophy. So eye of tiger is different and lamellated appearance or tigroid appearance, leopard skin appearance or tiger skin appearance is different. So eye of tiger is given Haloverden-Sparks disease, also called as PCAN, pantothenate kinase associated neurodegeneration. There is iron deposition in the globus pallidus. Iron is deposited in globus pallidus. That is Haloverden-Sparks disease. Tigroid appearance or lamellated appearance or leopard skin appearance that is seen with metachromatic leukodystrophy. So be careful whether he is asking eye of tiger or a tiger skin appearance. Can you tell me what do you see in CJD? Any radiological finding that you see in CJD? Radiological finding in CJD? You will see cortical ribboning, gyral hyperintensities. This is called cortical ribboning. Right? The cortex, the gyri will be hyperintense. That is cortical ribboning. What is the finding you see in MSA type C, multisystem atrophy type C? You see hot cross bun sign. Hot cross bun sign on MRI. And what is the appearance that you see in Wilson's disease? What is the appearance that you have in Wilson's disease? In Wilson's disease, you see a panda sign on MRI, face of giant panda. Face of giant panda. So these are important things on the neuroimaging. Haloverden-Sparks disease, eye of tiger. Cortical ribboning is seen in CJD. Multisystem atrophy type C. This shows you hot cross bun sign of the pons. Wilson's disease shows you face of giant panda sign. Okay, it's a radiological anatomy image, simple image. Can you tell me what is marked by the given arrow? What is marked by the arrow? Identify the mark structure in the given arrow. So this is the right side. This is the left side. This is the caudate nucleus abutting the frontal horn of lateral ventricle. On either side of the third ventricle, this small slit-like area is third ventricle. The black slit-like area is the third ventricle. On either side of the third ventricle, you see the thalamus. And this is the lentiform nucleus. And this is the anterior limb of internal capsule. This is the posterior limb of internal capsule. So what is marked here is the lentiform nucleus, lentiform nucleus. And this is the anterior limb, and this is the posterior limb, the black color areas. The anterior limb of internal capsule is this one. This V-shaped internal capsule, anterior limb and posterior limb. Between the lentiform nucleus and the caudate nucleus is anterior limb. So this is the caudate nucleus and lentiform nucleus. Between lentiform nucleus and caudate nucleus is anterior limb. Between thalamus and lentiform nucleus is the posterior limb of internal capsule. You're seeing the V-shaped internal capsule. So remember this important parts of the basal ganglia. Okay. Which of the following isotope is used in the treatment of prostate cancer? What do you mark for this? What did you mark for this question? Which of the following isotope is used in the treatment of prostate cancer? Now, these iodine isotopes are important. Okay, iodine isotopes are important. What did you mark? Okay, very good. Very good. So please remember, when you're going for treatment of prostate cancer, you can have two types of brachytherapy that can be given. One is called low dose rate brachytherapy, and one is called high dose rate brachytherapy. In low dose rate brachytherapy, inside the prostate gland, we put seeds of iodine 125. Iodine 125 seeds are kept. In high dose rate brachytherapy, inside the prostate gland, you have wires of cobalt 60. Okay, cobalt 60 wires are kept. So the isotope used for low dose rate brachytherapy for prostate cancer is iodine 125. For high dose rate brachytherapy, we use cobalt 60. And remember, iodine 131, this is not for prostate, this is for thyroid. And this is not by brachytherapy, this is systemic radiotherapy given orally to the patient for thyroid cancer. Iodine 123 is not for treatment. This is for radioactive iodine uptake studies. Okay, thyroid scintigraphy studies is done by iodine 123. Brachytherapy, low dose rate brachytherapy is done with iodine 125. And this is for prostate cancer, mainly for prostate cancer. We use this iodine 125. So this is about the radioactive iodine. Iodine 124, yes, agree. Iodine 124 is for positron emission. This is PET scanning that we have, right? So these were some important questions that I wanted you to practice. And a few things, let me see if, because of the recent question that came in, Honda sign on bone scan. Honda sign on bone scan. Can you tell me, where do you see in INSET? I've taught you this in your, nuclear medicine introduction chapter also. If you followed the live classes, we have discussed this topic in the introduction topic itself. When I'm teaching bone scan, I've discussed this Honda sign. So whenever you have sacral insufficiency fracture, so in the sacral ala, you see normal uptake of bone scan. But when we have sacral insufficiency fracture, osteoporotic fracture of the sacrum, so you see tracer uptake in this area. So this whole appearance of the sacral insufficiency fracture, it gives us a symbol of the Honda car, right? So this is Honda sign. So Honda sign on bone scan is sacral insufficiency fracture. Sacral insufficiency fracture. And if I ask you, where do you see double density sign on bone scan? Double density sign on bone scan. Double density sign on bone scan. So you see a lesion in the diaphysis of the upper femur, in the cortex of the upper femur, in the diaphysis. You see a central nidus with sclerotic rim. In the diaphysis of the upper femur, you are seeing it. In the cortical base lesion, showing a central nidus with a sclerotic rim. This is double density. This is osteoid osteoma. Osteoid osteoma. Causing pain in the night relieved with aspirin, right? So this is osteoid osteoma. Radiofrequency ablation, right? For osteoid osteoma. So this is osteoid osteoma. So pain in the night relieved with aspirin. Therapeutic test with aspirin, radiofrequency ablation. And because it's cortical based, what should be the investigation of choice? This is CT scan. For osteoid osteoma, the investigation of choice will be CT. This is about double density sign on bone scan. One more thing that we have on the bone scan is Mickey Mouse appearance on bone scan. This time they asked Honda sign, but in case they ask Mickey Mouse appearance on bone scan, can you tell me, where do you see Mickey Mouse appearance on bone scan, guys? Mickey Mouse appearance on bone scan. Last thing, Mickey Mouse appearance on bone scan. So imagine this is the vertebral body. These are the post elements, the transverse process and all. So you're not seeing just sclerosis of just the vertebral body. You're also seeing sclerosis of the post elements. That is the transverse process also. So if you have a densely sclerotic vertebra, that is ivory vertebra. So when you have densely sclerotic vertebra or ivory vertebra, you have osteoblastic activity not just in the vertebral body, but also in the post elements, giving a appearance of a Mickey Mouse. So Mickey Mouse appearance on bone scan. This is suggestive of Page's disease. So if you ivory vertebra is seen in. So it's a densely sclerotic vertebra, not just the vertebral body, but also the post elements are sclerosed, giving a Mickey Mouse appearance on bone scan. So remember these three things with the bone scan tested in the exam. Honda sign on bone scan is sacral insufficiency fracture. Double density sign on bone scan is osteoid osteoma. And Mickey Mouse appearance on bone scan. This is Page's disease. Page's. So these were some very important questions that you just have to not miss out on the exam. Some standard questions that I have kept you, and I hope your preparations are going smooth. And do daily, the NEET 2020. This will be a very good practice right close to your exam. That question practice should not go away. Even though when you're revising your notes, when you're revising your contents and all, always see that you have this regular practice of your MCQs going close to the exam. And stay determined, stay hopeful, and you'll have a good exam. Okay, so don't worry. Just keep revising your notes, and you should have a good exam. Okay, thank you so much. Best wishes all of you. Okay, take care, guys. All the best, everybody. Anuj, John, right? Shruti, everybody. Have a good time. Ajay, Dinesh, all of you. Asmita. Take care, guys.